offering to speak.
Thanks, Dr. Stillman. The topic today is characterization of liver lesions by MRI. I have no financial disclosures, and of course, I'm a radiologist. I have no money. Eyes do not see what the mind does not know. So, goals of the talk are characterization of the liver masses by MRI. We'll briefly touch on the imaging protocol, malignant versus benign differentiation, and then discuss the specific diagnosis. The protocol, as we know, T1 weighted out of phase and in phase images are employed in liver almost always. And T2 weighted images, we can use fast spin echo imaging with or without fat saturation, and then single shot fast spin echo imaging. One is with shorter echo time and the other is with almost double the echo time, 180 milliseconds, and I'll discuss those. Why do we use in and out of phase imaging particularly in the liver? We know from our MR physics that fat and water precess in and out of phase. On the 1.5 Tesla magnet, the precession out of phase is 2.2 milliseconds, and then in phase occurs at 4.4 milliseconds. As they precess in and out of phase, once they are out of phase, there is drop of signal as they cancel the signal intensity of each other. And you can see this is the same patient. The in-phase images, the liver intensity, signal intensity is quite different to the signal intensity on out of phase. You can still see the vessels traversing through the liver parenchyma. So there are no mass lesions here, but there is diffuse fatty infiltration. And on out of phase images, there is complete loss of signal as they cancel each other out. There is also a phenomena where a disease entity where the loss of signal intensity is on the longer echo or the in-phase images. And the reason for that is that wherever there is susceptibility within the liver parenchyma or parenchyma of an organ, there is loss of signal intensity. And this occurs especially with hemochromatosis or hemosiderosis, because the susceptibility effects of hemosiderin or any metal in the local magnetic field causes inhomogeneity and loss of signal on the longer echo. We also do T1 weighted spoiled gradient echo 3D imaging with fat saturation, and we do a few sets of images, pre-gadolinium, post-gadolinium, which can be arterial, portal, and delayed, and additional delayed imaging can be also undertaken if we've administered EOVIST or BOPTA. T1 weighted images are employed to look for fatty infiltration, which can be focal or diffuse. Fat within lesions can be assessed, and lesions that contain fat are commonly adenoma, HCC, and rarely lipoma. Melanin or melanin metastasis can also be assessed because they have high signal intensity on T1 weighted images. On T2 weighted images, again, it assists us with lesion characterization for cysts, hemangiomas, FNH, and HCC. Dynamic images are done for enhancement characteristics. Two types of contrast can be employed: extracellular agents or hepatobiliary agents. Multi-Hance was the first hepatobiliary agent, and 5% of it is excreted through the biliary phase, and which occurs at 1.5 hours, the peak biliary phase. With EOVIST, since it is excreted, 50% of it is excreted through the bile ducts, biliary phase occurs early and can be imaged at 20 minutes. Dynamic MRI and late biliary phase can also be employed. So talking about focal hepatic lesions and the features that aid diagnosis: margin and definition, signal intensity on T1 and T2 weighted images, in and out of phase images to assess for fat or iron within the lesion, enhancement pattern, central scar, and pseudocapsule. Clinical features that can help: if there is a known primary, we suspect metastasis. Age, obviously elderly are more likely to have malignant lesion, that could be primary malignancy or metastatic disease. Females with incidental lesions are more likely to turn out to be benign. If there is history of chronic liver disease or elevated alpha fetoprotein, we suspect HCC. And if the patient is on oral contraceptives or a bodybuilder who's taking steroids, we suspect adenoma. Rarely some literature has cited as FNH, but that's controversial. So we'll talk about enhancing lesion, and we'll talk about benign and malignant lesions. The three things that I would like to emphasize, and I've gone through all the literature and I've looked through most of the books, and there is always an argument that certain lesion is iso-intense versus hypo-intense, or certain lesion is hyper-intense versus iso-intense. And it is very, very difficult to remember because it varies from publication to publication and it varies from book to book. The three things that I would like to emphasize are, for a lesion to be worrisome, first of all, it has to be infiltrative. Secondly, it has to demonstrate washout. And thirdly, if a lesion is being followed up, for example, in a cirrhotic, and it changes signal intensity, you have to worry. So those are the three basic things and themes that I'm going to discuss here. So let's look at a few lesions here that are enhancing. First lesion, this is a lesion that has a central stellate scar as seen here. If we take a pencil and try to draw it out, it looks a little bit heterogeneous, but it is very well defined, so it can be drawn out. On T2 weighted images, again the central scar is noted. If you do fat saturated T2 weighted images, the lesion stands out because the background peritoneal fat or subcutaneous fat gets suppressed, so that helps. On arterial phase, the lesion enhances. On portal venous phase, the lesion almost becomes iso-intense with the liver. The central scar is again noted, which is hypo-enhancing. On delayed imaging, the lesion again remains iso-intense and the central scar demonstrates enhancement. On delayed EOVIST images, the lesion is iso-intense to the liver, which means it takes up EOVIST. So the lesion has a scar, it is well circumscribed and does not demonstrate washout. And the additional feature is that it takes EOVIST. Hence, by definition, it is FNH. So additional features, as I said, central scar, which is high signal intensity on T2 weighted imaging. The central scar is hypo-enhancing early and enhances on delayed images, and the lesion takes up EOVIST. It's a conglomeration of benign hepatocytes with malformed vessels and bile ducts. As I said, on signal intensity on T1 and T2 pre-contrast T1 and T2 weighted images, it says, some books say iso-intense, some say hypo-intense, some say on T2 it's iso-intense versus hyper-intense. But as I said, key features, arterial phase, homogeneous blush. Delayed phase, it is iso-intense, which means does not demonstrate washout. It takes up EOVIST. Additional features which can be seen, but not always, are thin central scar, radiating septae, and incomplete pseudocapsule. The second lesion, again an arterial phase MR, which demonstrates an enhancing lesion. On in and out of phase images, the lesion actually does not demonstrate any drop of signal, but the liver parenchyma itself demonstrates dropout, which means the liver contains fatty infiltration. On T2 weighted images, the lesion is well circumscribed. Again, if you take a pencil and you try and draw it out, you can draw the lesion out very well, which means it is very well circumscribed. Arterial phase, the lesion enhances. Portal venous phase, the lesion is still enhancing. There is no demonstrable washout on delayed images. You can see a thin rim or border of enhancement around it, which equates to a pseudocapsule. Let's see how it behaves on EOVIST images. Delayed EOVIST images, the lesion is hypo-intense, which means the lesion does not demonstrate uptake of EOVIST. So the lesion is well circumscribed, does not demonstrate washout, and does not take EOVIST. Liver contains fatty infiltration, and when we checked the history, it was a female on oral contraceptive pills. So this turned out to be a hepatic adenoma. It's a benign tumor in women taking oral contraceptive, as I said, or hepatocyte stimulating agents like steroids. T1 weighted images, it can be variable because it can either contain fat or it can be a hemorrhagic lesion, and any of those features would render it heterogeneous signal intensity. On T2 weighted images, again variable but usually hyperintense. Arterial phase, as I said, it's hypervascular. Delay phase, it's iso-intense, although some books do talk about that. Rarely it can be hypo-intense. Additional features, as I said, delayed enhancing pseudocapsule, as was demonstrated in our images. Intracellular lipid, and can be heterogeneous if there is hemorrhage within the lesion or fat within the lesion. Adenoma versus FNH. With BOPTA, a few trials were done. I've just demonstrated one here. It was highly accurate for differential diagnosis of FNH from hepatic adenoma or liver adenomatosis. And out of 100 cases that they did the trial on, 93 were confidently diagnosed in the first run, and the remaining were diagnosed confidently on follow-up imaging. Let's talk about the third lesion, another arterially enhancing lesion within the liver. Hypo-intense on T1 weighted images, hyper-intense on T2 weighted images, and when we do single shot fast spin echo, it remains hyper-intense. So there are lesions that demonstrate loss of signal on longer echo, and those lesions sometimes can be variable. But if the signal intensity is maintained as hyper-intense, then you think of a benign entity. On arterial phase images, the lesion is enhancing. On portal venous phase, the lesion is still enhancing. And on delayed images, it continues to follow the blood pool. And any lesion that continues to follow the blood pool, we think of a hemangioma. And this lesion actually follows the blood pool, enhances, well circumscribed. This was a flash filling hemangioma, a benign lesion. So enhancement patterns of hemangiomas, there are three types. Type 1, immediate complete filling, which is in small hemangiomas less than 1.5 centimeter. Type 2 demonstrate peripheral nodular filling, which completely fill in on delayed imaging, and type 3 demonstrate peripheral nodular incomplete filling. That is the case in giant hemangiomas, which are greater than 5 centimeter. So let's look at type 2 hemangioma. Well circumscribed lesion. There is some discussion about a characteristic cleft, that if these characteristic clefts, if seen, these facilitate the confident diagnosis of a hemangioma. Again, on arterial phase, you can see peripheral nodular incomplete progressive filling in, and if you wait long enough, the lesion inevitably completely fills in. But we can't always wait 15 minutes or 20 minutes or 30 minutes for the lesion to demonstrate complete filling in, and we cannot entirely rely on that. Peripheral nodular incomplete rim of enhancement that progressively fills in quite confidently renders the diagnosis. Type 3 hemangioma, again we can see there is a large lesion in segment 5 which is exophytic, rising from the inferior surface, and there is also a smaller additional lesion. T2 weighted images, you can see the large lesion well circumscribed. If you take a pencil, you can again draw this lesion out. It is large, but it is very well circumscribed. The second lesion also is well circumscribed, and that's the gallbladder hanging in between the two lesions. On arterial phase images, you can see there is enhancement within the lesion, which is peripheral nodular puddles of enhancement. The second lesion also demonstrates enhancement. There is progressive filling in, as you can see. It does not completely fill in, and these are delayed EOVist images. The lesion is hypo-intense to the liver parenchyma, which means it does not take EOVist, and both lesions actually demonstrate progressive filling in. So the larger lesion was actually type 3 hemangioma, and the smaller lesion was a type 2 hemangioma. Both are benign lesions. Incomplete rim of nodular enhancement that increases centrally over time. As I said, complete filling sensitivity goes down, but specificity does not increase, because we always cannot wait 30 minutes or 40 minutes or 50 minutes to keep the patient in the scanner and re-image repeatedly to make sure that it fills in. But it's, whenever there is characteristic cleft, well circumscribed lesion that does not demonstrate washout and demonstrates progressive filling in, that is sufficient for us to be confident that it is a benign lesion. Next lesion is also a lesion within the enhancing hypervascular lesion within the liver. It is well circumscribed. Let's look at it. In phase images, the lesion is not well demonstrated, but on out of phase images, you can see drop of signal, which means this lesion contains fat. The entities that contain fat and commonly encountered are adenoma and HCC. So let's talk about those two. On T2 weighted images, you can again, the lesion is barely demonstrable, but there is this heterogeneous focus within it. On arterial phase images, as I said before, lesion enhances, but something else is going on here. On the delayed images, the lesion actually, most of it demonstrates washout. there also is a thin rim of a rind of enhancement, persistent enhancement around it, which is a pseudocapsule. So a lesion which was well circumscribed, high signal intensity on T2 or heterogeneous on T2 weighted images, but the most important thing is demonstrates washout. So we checked, and this patient actually had elevated alpha-fetoprotein and history of Hep C. This turned out to be hepatocellular cancer. Additional features can be lipid capsule, lipid content within the lesion, elevated alpha-fetoprotein, and also sometimes a demonstrable pseudocapsule. This is the most common malignant liver tumor. On T1 weighted images, the lesion can be of variable signal intensity because it can contain hemorrhage or fat like an adenoma. On T2 weighted images, again, it can be variable due to the above factors. Arterial phase, it is hypervascular. Some literature talks about it being hypovascular as well. And delayed, it is hypointense because it demonstrates washout. Additional features can be pseudocapsule, scar, and history of cirrhosis, Hep B or Hep C. Let's talk about regenerative and dysplastic nodules. Due to angiogenesis and due to certain hormones secreted within these tumors, as these go from regenerative to dysplastic to frank HCC, angiogenesis increases within these lesions. So here is a liver, and if you were somebody interested in lotto, you could say that this patient actually won the lotto for liver lesions. There are a gazillion or 100 million lesions here, and on T2 weighted images, all of these lesions are hypointense. There are these streaks or strands of high signal intensity separating some of these lesions, which are low signal intensity on T1 and high signal intensity on T2. And we know that as this process of cirrhosis and liver destruction progresses, there is fibrosis occurring within these or separating these regenerating nodules. And normally fibrosis is low signal intensity, as we know in the case of fibrosis anywhere in post-surgical areas or in fibroma or fibrothecoma of the ovary. But in liver, sometimes fibrosis can be high signal intensity on T2 weighted images. And the reason for that is because of active inflammation. This is hydrated fibrosis, an ongoing fibrotic process. On arterial phase, the lesion enhances, and the lesion none of these lesions demonstrated washout on portal venous or delayed imaging, and therefore these lesions were regenerative nodules. Let's talk about dysplastic nodule and an HCC. This patient had a history of hepatitis, and alpha-fetoprotein had started rising, so we did a repeat imaging. Normal interval was 1 year for this patient, but now we brought the patient back earlier. You can see a lesion in segment 7 of the liver, and on out-of-phase images, a part of this lesion, the medial part of this lesion, demonstrates loss of signal intensity. The same part, the medial part which demonstrates loss of signal intensity, has high signal intensity on T2 weighted images. On pre-contrast T1 weighted images, you can see the lesion as hypointense, but the part that is high signal intensity on T2 demonstrates loss of signal intensity on out of phase, actually demonstrates enhancement, is hypervascular, and then demonstrates washout. So I called up the clinician and I said, this patient has an HCC, a focus of HCC within a dysplastic nodule. And the clinician asked me as to what I was smoking. And I said, nothing new. So this lesion, he said, how the hell can you be so confident? You're not looking up things under a microscope. So you're not seeing the cells. How can you be so specific about dysplastic nodule plus an HCC? Anyway, got explanted. So he called me up and he said, whatever you're doing is working. Good, keep doing it. You were right, So regenerative and dysplastic nodules, T1 weighted images can be variable. T2 weighted images, usually hypointense. As I said, if you're following up a patient with a liver lesions, especially with hepatitis or has cirrhosis, and the lesion signal intensity changes, you've got to worry. You've got to actually look closely at the lesion again. Arterial phase, the lesions are hypo to iso-intense and delayed. There is no washout. These are regenerative and dysplastic nodules. As I said before, any lesion that demonstrates washout, you've got to worry that it's not a benign lesion. It's an entity that needs to be looked at or biopsied. So additional features: liver can demonstrate cirrhosis, history of cirrhosis or hepatitis. Let's look at our next friend, hypervascular lesion in segment 3 of the liver. The patient had a history of colorectal cancer. You can see the lesion is hypo-intense on pre-contrast T1 weighted images, mildly hyper-intense on T2 weighted images. Arterial phase, as we saw before, enhances portal venous phase. It definitely demonstrates washout. And EOVist, it does not take it up. So by definition, any lesion that demonstrates washout is worrisome. This actually turned out to be colorectal metastasis, and a few months later, the patient's liver was unfortunately riddled with mets throughout. So let's look at metastasis versus hemangioma. These lesions can initially, in the early arterial phase, cause a little bit of confusion, never on delayed. But you can see in arterial phase, there is almost a complete rim of enhancement around the metastasis, whereas, as I said, hemangioma demonstrates peripheral nodular incomplete rim of enhancement. So it's an incomplete rim. There is no enhancement over here, and there are sort of thick puddles of enhancement. And on portal venous phase, you can see this is progressively filling in, whereas this lesion does not demonstrate progressive filling in. So that is how you tell them apart. Metastasis usually irregular in shape and margin. T1 weighted, usually hypo-intense, but can be hyperintense if it is melanoma metastasis or mucinous or hemorrhagic mets. T2 weighted images, hyperintense, heterogeneous, and a blurry edge. Arterial phase, hypovascular peripheral, a thick rim, hypervascular homogeneous, less than 2 cm, and if it is larger than 2 cm, the enhancement is heterogeneous. Perilesional enhancement can sometimes be seen in pancreatic and colorectal mets. Portal venous phase, irregular peripheral washout. Let's talk about our next friend. You can see an infiltrative sort of lesion. If you take a pencil, you can definitely not draw it out. You cannot figure out the boundary of this lesion. Additionally, this patient had Crowley's disease. You can see multiple dilated bile ducts in the liver. This is a large lesion hanging down from segment 5 of the liver. On arterial phase, heterogeneous enhancement which persists. There is no washout within this lesion. So this was a cholangiocarcinoma, which is a malignant tumor of bile duct origin. Arterial phase, hypo-enhancing, and delayed phase, it demonstrates heterogeneous delayed enhancement. Additional features are history of ulcerative colitis, primary sclerosing cholangitis, choledochal cysts, or polyposis syndromes. Let's talk about some more arterially enhancing lesion. So here is a lesion that is sort of well circumscribed, light bulb-like, the same as the arterial phase or enhancement within the aorta. There is a triangular wedge which extends from the lesion onto the liver surface. On T2 weighted images, the lesion is again demonstrable. Subtle hyperintensity arterial phase, again the same as I described on coronal reformats. You can see the peripheral wedge. And on portal venous phase, the lesion is still enhancing, does not demonstrate washout, and is following the blood pool. So this lesion actually was a pseudoaneurysm of the hepatic artery with an arterioportal shunt, and that is why you see this segment of the liver, the blood supply to this segment of the liver is taken up by the arterial supply. Normally, the liver is supplied 70% or 80% by the portal vein and 20% or 30% by hepatic artery. But when there is a fistula, the arterial blood is pulsatile and under pressure, and it overtakes the portal venous supply. And that's why you've got this wedge of enhancement or blush or transient hepatic enhancement difference, as it is called, but there's no washout, and that explains the phenomena of the blush that you see around that nodule of enhancement. So let's look at the next lesion. This was a cirrhotic, and there is well circumscribed subcapsular region of enhancement. On T2 weighted images, it's not demonstrable. On pre-contrast T1 weighted images, I'm sorry, the image is dark and this is covering the lesion probably, but take my word, it's not seen. In arterial phase images, you can see the lesion here, but on portal venous phase, this does not demonstrate washout. So there's no hypointensity here. So this was a patient who's on cirrhosis, who was on surveillance for cirrhosis, and this is a phenomena which is commonly seen in cirrhotics, that there are these arterioportal shunts in the subcapsular region, but the most important thing is there is no washout, and that is what helps us be definitive in our diagnosis that this is not a worrisome lesion. Let's talk about the next lesion, an arterially enhancing lesion in segment 7 of the liver. This patient had undergone a liver biopsy, again a cirrhotic, being followed up for assessment of development of HCC. Hypointense on pre-contrast T1 weighted images, arterial phase images, well circumscribed enhancing lesion. When we did our reconstructions, this turned out to be a veno-venous fistula. That's the branch of the right hepatic vein, and that's the right branch of the portal vein, and they both come together and mimic this lesion. So this was actually an iatrogenic lesion, but again did not demonstrate washout, followed the blood pool, and was well circumscribed. Let's look at our next lesion, again segment 8 of the liver, an enhancing lesion. Portal venous phase does not demonstrate washout, and when we did our reconstructions, this turned out to be actually a arteriovenous fistula, the branch of the hepatic artery coming in, and then branches of the portal vein filling in. And this was again an iatrogenic fistula. This patient, as you can see, nodular irregular contour of the liver. This patient got a biopsy of the liver and had developed a fistula, which showed up as a hypervascular lesion on the MR. Let's look at a few more lesions. Left lobe of the liver, there is a heterogeneous lesion with thick internal septation. T2 weighted images, again you can see the hypointense septation with multiple locules of enhancement within the lesion. On pre-contrast T1 weighted images, the lesion is again depicted enhancing septa. There is no washout within the septa or within the lesion. This patient was very, very sick and ill, turned out to be a hepatic abscess. So there's no enhancement, and obviously the white cell will be elevated, ESR will be elevated, and the patient will be extremely sick. Here is another lesion that has multiple daughter cysts within it. I'm sure what a bell rings up each time daughter cyst, the word daughter cyst is mentioned, and again you can see multiple daughter cysts within this well circumscribed lesion, and there is no specific pattern of enhancement or washout within this lesion. And there is also another additional lesion near to the primary site. This actually patient had a positive Cassoni's test, and this was a hydatid disease of the liver. Be ready for surprises in life. So additional features in lesions that can confuse us or sometimes can help us are a central scar, pseudocapsule, and intracellular lipid. Lesions that commonly depict central scar are FNH, hemangioma, and fibrolamellar hepatocellular cancer. I actually had a lot of difficulty pronouncing this. So I would put in my report FLHCC, and the clinician would call me and say, "What do you mean by that?" And I would say, "Please Google it." So